Bismillah ar-Rahman ar-Rahim. This is Assistant Professor Tariq Koraitim. I'm an Assistant Professor in the Head and Neck and Endocrine Surgery Unit. Our lecture today will be entitled Diagnostic Aids in Surgery. I would like to start our lecture by this tip that أشرف علوم الدين هي الفقه وأشرف علوم الدنيا هي الطب. قول الإمام الشافعي نتبارك به ببداية محاضرات هذا العام إن شاء الله. The definition of diagnostic aids are these aids by which we can reach the diagnosis, and these include history, clinical examination, and investigations. First, history, talking with the patient, writing down what he says, is to communicate through language. To do this, you have to have a background about the disease you are dealing with. This communication is to get information from the patient, to filter it, to analyze it, and to conclude from it. Types of history include personal history, present history, past history, family history, drug and immunization history, and for the females, the menstrual history. Details of each type of history is not of so importance, but we have to read something or know something about it. The personal history is the name of the patient, his sex, his residence, his job, his nationality, his personal habits. Present history means what is the history of the presenting condition. When did the condition start and how did it propagate? Past history means history, the medical history of the patient before this presenting condition. If there is any relevant diseases in the family of the patient, either relevant to the presenting condition or relevant to his diseases, should be narrated in the family history. Drug and immunization history, and of course by drug we mean the drugs that are taken with considerable amounts for considerable amount of time. We do not mean drugs that an analgesic that is taken whenever the patient has headache. Drugs we mean antihypertensives, anti-diabetics, corticosteroids for long periods of time for example, rheumatoid arthritis or systemic lupus and so on. And menstrual history, most important is the age of menarche and age of menopause, and if there is any recent change in the regular habits of the female. The second part of the lecture is about clinical examination. Information about the disease and the region, skills of examination, and tools of examination are the three pillars of this clinical examination. Tools of examination, we'll start with the last item. Tools of examination include gloves, thermometer, stethoscope, sphygmomanometer, torch, tongue depressor. Techniques of examination. How to examine? We either examine the mass, and I will concentrate upon the mass because in surgery, most of our cases deal with a lump, a mass, something that is felt and the patient does not know what is this. So, examining a mass, we either examine it by the general scheme of examination that we are going to tackle, or it is a special organ, so it needs a specific examination. And we will have examples about this. To start knowing what is the difference between general examination of a swelling and the swelling of and the examination of a special organ, we have to have this example. If I tell you what are the criteria of this fruit, you can tell me that it is rounded, orange in color, smooth in surface. From inspecting the umbilicus, we can state whether it is sweet or sour, that it is solid and heavy. These are the items that we can conclude from such a picture. But if we give this picture to a student in the Faculty of Agriculture, not in the Faculty of Medicine, he will get us much more information from this picture than we have already said. For example, he will tell us that it should consist between 11 and 13 lobes. Okay, why? The eye doesn't see what the mind doesn't know. So we have to know first what are we going to inspect and palpate in each swelling before we do this inspection and that palpation. So the general examination of a swelling is inspection using my eye and my eye only, palpation using my hand, percussion, auscultation, and then we can comment and we should comment upon the draining lymph nodes, do some measurements, movements of the nearby joints, and pressure on the nearby structures if there is any. On our scale as students in the Faculty of Dentistry, we will concentrate upon the first two items, inspection and palpation. Inspection, by inspection we mean that we are going to comment upon the following items as regards the swelling in question. The site, the size in centimeters, the color, and by the color we mean color of the mass if it is arising from the skin. If not, then we comment upon this item by saying that the color of the swelling cannot be judged if it is arising from a layer deeper than the skin. The shape, and by shape we have these examples. However, usually we use only rounded or ovoid or irregular for most of the masses. The surface, and by the surface we can describe these 7 descriptions. However, for the sake of simplicity as well, we either use smooth or lobulated or irregular to describe a surface of a swelling. The edge, it's either well-defined or ill-defined. The number, the pulsations, whether the mass is pulsating or not. Impulse on cuff, whether the mass increases in size and tension when the patient cuffs or not. And lastly, in the inspection, the skin over this swelling. As regards the palpation, we have to comment upon the temperature of the swelling, whether it is equal or higher than the surroundings, tenderness, whether it is tender or not by palpating it, and then we have to confirm the items of inspection before going to the number 4 or the first item of palpation of high importance, which is consistency. And by consistency we mean whether the mass is soft like the ear lobule, firm like a relaxed muscle, hard like a contracted muscle, or stony hard like a bone. Fluctuation, it's a test by which we differentiate between whether the swelling is solid or cystic, and the solid and the cystic swellings, can be tested being solid or cystic either by fluctuation or by something called Paget's test that is used in special conditions, as we will see in the clinical rounds. Fluid thrill, whether palpating an area, palpating this mass in concern, gives us the feeling of that something running inside it. And of course, this is usually positive in case the swelling is highly vascular or is arising from a vessel. Translucency, when we put a light source in touch with the swelling. Does the swelling transmit light or absorbs light? If it transmits light, it will trans-illuminate. It will be as if glowing like a lamp. So this is a translucent swelling. If not, it's a trans-opaque swelling. Impulse on cuff, as we described it during inspection, but we mean in this case we are putting our hand on the mass to feel that it is increasing in size and tension during cuff or not, of course. Reducibility and compressibility, and these two items we have to differentiate between one another. Both reducible and compressible swellings disappear on pressure. When I press the mass with my hand, it disappears. But when I remove my hand, if it reappears spontaneously, then this is a compressible swelling, and it is used to describe vascular swellings. If it is reducible, then when I remove my hand, it will not appear spontaneously. It will only reappear if the patient does a certain maneuver, either coughs, sneezes, does a Valsalva maneuver, or if he's a child, he cries. Pulsatility, by palpation, we can differentiate whether the mass that was on inspection pulsating, whether it is pulsating by itself or transmitted from a nearby artery. As we see in the lower two diagrams, the transmitted pulsations means that the mass is pulsating because there is an artery passing behind it, inferior to it, deep to it. But it is expansile pulsations when the mass itself is pulsating. This means that it's arising from the artery, and this is either an aneurysm or an arteriovenous fistula. Fixity to the surroundings, or relation to the surroundings, by which we mean fixity to the surroundings, or we can switch it to an item called mobility, whether the mass is mobile in all directions or is mobile in a certain direction and restricted in the other, or restricted in all directions. Then, relation to the surroundings, we want to know whether the mass is superficial to a muscle, like the diagram on the left side, or within the muscle, as the one in the middle, or deep to the muscle, as in the one to the right. Clinically, we put the muscle into contraction. If the mass becomes more obvious, then it is superficial to the muscle. If it becomes less obvious when the muscle is contracted, then it is deep to the muscle. If it doesn't differ, but its mobility becomes restricted, then it is arising from within the muscle substance. The rest of the items can be commented upon in the clinical rounds. We don't have here the time or the ability to discuss them in details. The next section of examining a mass is the specific examination of an organ. For example, examining the parotid gland. Or the parotid duct. Or the facial nerve. Or the submandibular gland. Or the oral cavity as a whole. Or the thyroid gland. Or examination of proptosis in a case of toxic gland. Or examination for hypocalcemia in a patient suspected to have hypocalcemia. All these specific organs will be discussed in the relevant clinical rounds. Now we are left with the last part of our lecture, which is the part of investigations. And we have to know that investigations are as good as the clinician who ordered them, meaning that if you ask for investigations that are always coming to be irrelevant or unremarkable or negative, then you are ordering too much investigations. The first example of investigations are laboratory. Laboratory, by which I mean that I send the patient to the lab to do a blood test, a urine test, a stools test, or something else more sophisticated. The second pillar of investigations is to do imaging, that we send the patient to a radiology or imaging scanning center to have, and the examples will be given in a historical, chronological order. The very first type of examining a patient with an imaging procedure was the plain X-ray. The plain X-ray is very simple and very cheap and can be done through machines like these to show crude abnormalities. This is, for example, a plain X-ray for the neck and upper chest in a child that has swollen a coin. The plain X-ray is a cheap, easy, and fast investigation. Easy, I mean easy to interpret, and is done in everywhere and is very suitable for such a condition. If I have a mother complaining that her child might have swollen a coin, it's not wise or needed to send her with her child to do an ultrasound or a CT or an MRI. But a plain X-ray, like the one you are seeing, is the most suitable one. Also, a plain X-ray can show a stone related to the mandible, as here, as in case of a submandibular gland stone. Sometimes, when we do it for another purpose, we get such an astonishing picture of a calcified lesion in the neck, and this appears to be a calcified goiter. The next sophistication in the chronological ladder of investigations is to do the same X-ray, but after injecting a dye one way or another. For example, we can inject the dye into the duct of the submandibular gland, and then we have a plain X-ray to have such a picture of the normal duct and normal submandibular gland with its duct branching inside. This is another investigation which is not so relevant to our work, but to give an example. This is the esophagus of a patient having esophageal varices. He swallowed what is known as barium swallow or barium paste. So it fills the esophagus, appearing white when shot with plain X-ray, but the black grooves that you can see within the esophagus are called filling defects, and these are known to be esophageal varices. This is another example for an esophagus with a completely different picture. The lower part of the esophagus is not filled totally with dye, and the upper part and the middle parts of the esophagus are filled with much dye, and the esophagus is so dilated. So there is a stricture in the lower part, and this stricture, its character in the dye study, implicates that it is a malignant one. The third is the ultrasound, and the ultrasound idea is based upon the idea of the bat. As you all know, the bat is blind. However, he only travels during night, and he sends ultrasound waves from his head. Whenever the wave doesn't come back, then he can continue flying. Whenever the wave comes back, he senses from where did it come back. This means having an obstacle there, and so he changes his direction of flight and so on, as this picture diagram can show you. So Man invented the ultrasound based on this idea, having the waves transmitted and got back to a computer where it is translated into a picture that a gynecologist, for example, can use it to test the baby in a pregnant female and many, many other uses. Sometimes, as we can see here, we can see the blood going into a blood vessel, and this is called Doppler or duplex study. The advantages of ultrasound are being non-invasive, painless, no radiation exposure, no detrimental genetic or physical effect as those caused by X-ray, inexpensive, and sedation is not required. And also it requires no special preparation in most of the cases. Their disadvantages are technically limited in obese patients because ultrasound cannot be accurate in obese patients. The resolution gets much lower if there is bone or gas in the way of the waves. It's an operator dependent, means that there is a good sonographer and a lousy sonographer, but this is not the case in other investigations. And I have to tell you here, please, that in the book, in your book, in the department book that we are responsible about, there are some copying mistakes. في أخطاء مطبعية في الجزء بتاع الادvantages بتاعت ultrasound والسي تي. Please revise them from these slides because these slides are the ones which are correct. لكن الجزء اللي في الكتاب الراجل بتاع المطبعة نقل حاجة من غير ما يقصد، لو أنا فاكر صح، ما بين الالتراساوند والسي تي. فلو سمحتم راجعوا كويس الادvantages والdisadvantages بتاعت الالتراساوند والسي تي من هنا. Doppler and duplex, we mean that ultrasound is used to detect the motion of blood in the arteries and veins. The next investigative tool is the computed tomography, or CT. It is just the plain X-ray, but very condensed and computerized so that the waves come from this gantry. This circle is called gantry. The CT comes from many points around this CT gantry to pass through the patient and then comes from the other side to be received by a sensor. And this sensor sends this information to the computer to give us at last such a highly sophisticated, high resolution picture. Without going into details, you can see that to the left of the left thyroid lobe, there is a very big mass which is not present on the right aspect. So this is something that should be subjected to investigations and diagnosis. MRI, the same idea of having a patient going into a gantry where an MRI wave comes from a point and received after hitting the patient by a sensor on the other side, and this sensor sends the information to the computer to give much more sophisticated picture with many details. And of course, MRI is not more sophisticated than CT, meaning that when CT fails, we ask for MRI. This is not the case. And when ultrasound fails, we do not ask for CT or MRI. This is not the case. Every patient, every clinician who suspects something, then he has to ask for the investigation that is in concern, that can be useful for the diagnosis that he suspects. So he should first suspect something and then ask for the investigation for which is suitable. As we said in the case of the baby who has swallowed a coin, the plain X-ray is much easy and much simple and much cheaper technique. But if he asks for an MRI, it might be not as useful as the plain X-ray to detect the foreign body, and so on. So chronologically, plain X-ray came first, then ultrasound, then Doppler, then CT, then MRI, then radioactive isotope scans, as we'll see in a minute. But this chronological order does not mean the degree of accuracy in diagnosing everything. No. Plain X-ray that has been discovered more than 100 years ago is sometimes more useful than the MRI that has been invented in the 90s of the last century. Okay, the next investigation is the radioactive isotopes, and this means that we inject the patient with a radioactive material that we know that it has a special predilection for a certain organ. So we can scan the bone, we can scan the organs, we can scan the thyroid and parathyroids, and so on, by injecting or making the patient swallow a certain radioactive material. And then in all of these cases, the patient is photoed by what is known as gamma camera. After laboratory and imaging, there is endoscopy, where we can go with a very, very small telescope camera into the inside of a ductal structure to see what is inside. Examples for this are salivary gland ductoscopy, sinoscopy, direct and indirect laryngoscopy, upper and lower GIT, gastrointestinal tract endoscopy, and bronchoscopy. The fourth investigation is biopsy. Biopsy means that we take a part of the swelling in concern one way or another. Fine needle aspiration cytology means that we go with a needle, just a syringe, and we aspirate some cells from the mass and subject them to cytology by a cytologist. Brush cytology, that if we have an accessible lesion, then we use this special brush to take some cells from it. True cut needle biopsy, that we go into the inside of the mass, ultrasound guided or CT guided, percutaneous, under local anesthesia to get a part from the mass as a histological biopsy. This means that we do not have cells as in fine needle and brush cytology. We do have a part of the tissue to do histology, as we see in the diagram relevant. If all these fails or are unsuitable for the patient, then we go for what is known as incisional biopsy. We give the patient anesthesia, local anesthesia or general anesthesia, or even regional one, and then we go by the scalpel, we open the skin and the subcutaneous and the muscles, and we go to the inside of the mass, take a part of it, and go for the histopathology. Sometimes it is so large, so invading everything, that we have to do only incisional biopsy, and sometimes it is accessible, not attached to anything, and so we can do excision of the whole mass to be a diagnostic procedure, and maybe as well a therapeutic one, removing the whole biopsy, removing the whole mass, and giving final treatment to the patient. And last, the most important diagnostic tool for all that we have said is practice, is to do all these items once and twice and thrice and so on until you got good skills of practice to reach the diagnosis in the shortest and safest journey together with the patient. Thank you very much. And this is my email. If anyone wants to ask me about anything, I would be happy to answer your questions. Thank you very much.